Dr. Pezalla, can you explain how the benefit is most often billed for oral appliances to treat OSA?
So billing depends on who writes the prescription and is supplying the oral appliance. Most often these do come from dentists, and so therefore it is covered under the dental benefit. But if an ear, nose, and throat specialist or other physician writes for it, then more likely to be covered under the medical benefit, as they may source it from a non-dental lab, but from some other durable medical equipment provider.
Are most insurance plans now approving home sleep studies, and what is the criteria that's commonly used for that?
Yes, most insurance plans are now approving home sleep studies because they're less expensive and more readily available than going to a sleep center. However, there are usually criteria for what constitutes an acceptable sleep study. This includes measures of apnea, hypopnea, O2 saturation, and other standards of care.
What can health plans do to improve overall patient compliance with OSA treatments?
Compliance is a huge question, especially for CPAP and other things that are somewhat hard to use. Health plans can follow up with patients, especially those patients who have been prescribed CPAP, to find out if they're doing all right, if the equipment is working properly for them, and to encourage their continued use. It's also very effective if the provider can be in touch with the patient on adherence. And so coordination between health plan case management staff and some of the staff at the provider who initially prescribed the CPAP can be helpful as well.
Can you explain how appropriate therapeutic interventions and undiagnosed patients affect health plan costs?
Well, health plan costs are affected in several ways by patients who have obstructive sleep apnea. First, those patients who are untreated can eventually develop serious problems from it, including cardiac and lung disease. It contributes to obesity and to other problems which they may seek help for, so resource utilization is clearly higher in those patients. They may also have depression, anxiety, and other mental health issues, which also increases the cost of care for these patients. When you treat the underlying cause of the OSA, then the patient is less likely to have these problems. First, in the immediate term, they're less likely to use healthcare resources for undiagnosed problems, vague problems, and medications to treat some of the mental health side effects. In the medium to longer term, they may suffer fewer problems in the heart, lung, and other areas. And of course, these are larger savings, but sometimes are outside of the usual period of time that health plans use to measure benefits from treatment.
Are medications ever used alone for OSA, or always with or following the use of CPAP?
Medications don't really treat the obstructive component of OSA. They're mostly intended to treat the daytime drowsiness, some of the side effects of narcolepsy, and other problems like that. And so they really shouldn't be used alone, but there should be something used to address the obstructive component. That could be surgery, oral devices, or CPAP.
Are the newer, smaller CPAP devices also available with battery options for people who want to spend time off the grid, so to speak?
Yes, the more portable devices now have batteries. There's a wide range of devices available, and so if you do camping, if you're just going on vacation, if perhaps there's not access to electrical plugs and those sorts of things, you can still find a CPAP device that will work for you.
Under what circumstances would a patient go directly to a sleep study versus trying a pharmacological approach?
Many times it's better for patients to go to a sleep study as part of an overall assessment of their symptoms and what the problem is, as opposed to going straight to a pharmacologic approach, because the pharmacology basically helps patients to stay awake, but there may be other underlying causes and they may have other difficulties which really need to be addressed at the root of the problem. And so a sleep study is part of an appropriate overall workup, and many health plans require a sleep study or other sort of workup before patients receive specific medications for the daytime effects of OSA.
What services can health plans provide OSA patients to help increase adherence to therapies such as CPAP? What about pharmacologic agents for OSA?
Well, providing the other treatments in addition to CPAP can be really helpful for patients, because many patients who are using CPAP, and even patients who are compliant with the CPAP use, may still have excessive daytime sleepiness or other problems that can be improved through the use of some of the new medications. So having those medications available can make patients feel better, they feel like things are working, and they're more likely to stick with their CPAP and other parts of the regimen. As we also mentioned before, patients can be encouraged to continue with the CPAP or to go back and see their provider if they're having difficulty with the machine or feel that it's not working for them.
How does the recently approved solriamfetol differ from older agents approved for OSA, such as modafinil or armodafinil?
Well, it differs in a couple of important ways. First, in terms of mechanism, it actually is a dual reuptake inhibitor. So it inhibits dopamine reuptake, as the other drugs do, but also norepinephrine. So this improves its effectiveness and making it an agent that might work for the patients who don't get a response to the other agents. Also, because there's no release of monoamines like there is with amphetamines, it avoids rebound, and therefore it doesn't keep patients awake late into the evening. So it can be an important drug for those patients who don't respond to the other drugs, or for the patients who don't get a complete effect.
How might treatment be improved for patients adequately treated for OSA but still experiencing excessive daytime sleepiness?
First thing is to make sure that the problems of sleep, obstruction, and those sorts of things are actually being adequately addressed. That is the patient able to use the CPAP or other equipment properly, and does that equipment actually improve the situation for the patient, which might mean that they might need an O2 saturation study or perhaps even a repeat sleep test. And certainly for those patients who continue to experience daytime sleepiness, the medications that have been approved for that can be helpful in cases where they're not contraindicated for that patient.